sort of kind of thinking about what the goals were of this presentation and how to present such a broad topic to everyone and focusing on what might be most useful for you. Nutrition, very broad, and when you think about the age group that we're covering, you just have such different specifics for each group. So when we think about what's really new, there's been a lot with formula changes. It's really hard to keep up. Even myself, as focusing on the inpatient side of pediatrics, where the formulas are changing left and right, I find that a lot of the practitioners are really struggling to understand what the differences are. Also, vitamin and mineral supplementation. This can be an area where it's easy to, trip up when you're not thinking about all the different nutrients that, everyone would need, especially with the newer recommendations for vitamin D supplementation and the vegetarian and vegan patient, which we're seeing an increase in population. Common challenges, always the picky eater, very difficult, trying to think about that behavioral side of it that really is a take-home to all parents and working on behaviors around eating. And portion size, I think, is something to really look at, especially with, obesity. The objectives of this presentation is to really understand, again, the recent changes in the calorie concentration of the term-based infant formulas, provide accurate dosing recommendations for the vitamin and mineral supplementations, and really think about those take-home messages for parents around behavioral eating, and know when you can utilize and reach out to your RD to go that extra mile about what you might not be able to counsel your patients on. So infant formulas, what's new? There's reduced calorie formulas on the market now. They're 19 calories per ounce. Partially hydrolyzed formulas are still relatively new, and I'm finding that people aren't really understanding when and how they should be used, as well as the concern about probiotics popping up in a lot of the products, preparation, and also seeing some use of preterm formulas for term infants. This is a picture that I took actually at my local Target, really just looking at the aisle of formulas. And I think, if you're imagining yourself as a parent that's new, that's never had any experience with infant formula before, and you're standing in this aisle and you're ready to start, buying a product, how do you choose? And I think part of the issue right now, too, is the marketing is really, really strong for these products in parent magazines and online. And, it's hard to really, get aside from the marketing and really understanding, when the product is going to be beneficial. So Similac is actually now 19 calories per ounce, and there's a list. This slide's a little bit busy, but there's a list of all the products that changed from the standard 20 calories per ounce down to 19. Basically the background from it, reported by Abbott was that they felt there was, research to, argue that the breast milk calorie composition is closer to 19 versus 20, and that, formula-fed infants tend to gain weight a little bit more rapidly than those that are breastfeeding. So they wanted to reduce the 19 cal per ounce. So the biggest issue that I think a lot of us have as dietitians with this change is that not all of their products actually changed. The specialized products are still 20 calories per ounce, as well as the standard term products that they changed. They have to maintain a 20 cal per ounce product because the WIC guidelines still mandate that, if you're servicing WIC, you need to provide 20 cal per ounce formula. And so only certain containers of Similac have actually decreased to the 19 cal per ounce, which has really led to a lot of confusion and, kind of is an extra step that not only as a dietitian when I'm, assessing a patient to understand their formula history, and I have to really clarify, what product they've been on, and already it can be very confusing because you have the family name of Similac there, and, trying to tease out maybe even sometimes by label color what exact product they're using. Now I also have to really kind of inquire about the size can that they're purchasing of powder-based product so I can understand the calories that they're mixing. And I think that's just, been a little bit confusing. There was an AAP news statement release that said what pediatricians need to know about the low-calorie, low-protein formulas. And I think it was a good summarization to just be aware of the potential confusion, the change overall, and we need to kind of see where this is going to go in the future. So partially hydrolyzed products have been around for a bit, and actually one of the big things is the Gerber Good Start standard term product is 100% hydrolyzed whey, but yet still classified right along with, Enfamil and Similac as a standard term product. There's really strong marketing behind these products, and there's really limited evidence to support the use of them. Most babies really can just continue through and stay on a fully intact protein, which we know the breast milk-based protein is intact, or they might need to move beyond the partially hydrolyzed and go to the fully hydrolyzed products. One of the products is labeled specifically for fussiness, gas, and crying. I just tend to see, the crying aspect really can be a strong marketing tool for parents to say, oh, well, this formula can, alleviate my baby from crying. And I think that's a little bit unrealistic to expect. And hopefully most people would be knowledgeable enough not to understand that, it would be all crying, but maybe a crying associated with colic or gas pain or things like that. But, clearly when you have crying on the label, I think it's a little bit, misleading. And the products that would be included in those partially hydrolyzed, aside from, the Gerber Good Start, would be the Enfamil Gentlease, Similac Total Comfort, Gerber Good Start Soothe, which also has a probiotic in it. And the Similac Sensitive really doesn't even fit into this category, but I think a lot of people feel that it does, and they don't really understand the product and the fact that it actually contains intact milk proteins, but it just has a lower lactose content for it. Probiotics and infant formulas, so, just to understand pre and probiotics, the probiotic is actually a viable organism, and you're only going to find the probiotics added to the powder-based products because the liquid-based products have to go through such a sterilization process that you wouldn't be able to keep a viable organism in there. So, most of the research seems to show that it's safe, but I think you have to step back and take caution about when you really want probiotics in your formula, because those infants that might become or are immunocompromised or all of a sudden become seriously ill, you might want to rethink the benefit of having that bacteria in there. Even though we consider it to be good bacteria, it's still an introduction of bacteria. I've actually had several cases in our pediatric intensive care unit where patients were on Nutritional and actually came in, very critically ill and, immunocompromised in the ICU. And we actually decided to change their formula for the reason of just, being conservative and not having the probiotic present. So formulas that contain probiotics are listed on the slide. Nutritional, I think, being the biggest one because I feel like not everyone is really realizing, it was just a regularly, pretty frequently used partially hydrolyzed product, and all of a sudden, it's changed and has the probiotic in it, and I think people aren't always realizing, that probiotic was in there and added, and it's something definitely I'm finding parents are certainly not aware that it's there and kind of why it would be there, the pros and cons behind it. And the cost versus benefit. So I see this often, especially in my inpatient side of practice, where, I have extreme cases of failure to thrive coming in, and, reading their formula history is like reading a novel. They've been on, 10 different products in a period sometimes of 2 or 3 weeks, and you really wonder, how much of a trial was actually given? Was it a good 3 to 5 days to really see if they could tolerate the product, if there was a benefit to it? And then the other thing that I see often is, kind of the A to Z effect, where, you kind of are on breast milk or standard intact protein formula, and all of a sudden you're going to a full elemental amino acid-based product without trying anything in between. These products are very expensive as you go down the ladder to the more broken down protein products, and you have to really think about, did they have a good trial on something in between, especially when you're, kind of challenging and bringing it to the insurance companies. They're going to really kind of question you to say, well, why did you go from A to Z? What about, M, for example? And, if you didn't really show that the baby didn't tolerate that, they might, balk at covering the cost of the more expensive products. So, and then insurance doesn't always cover all of these products for all patients. So it's something you do have to kind of step outside and think about the impact on what it will be for the family. And just here's a slide that includes the sample retail pricing. So this was, I surveyed kind of 3 online sites to get an average cost per can of the different products. So definitely, try to include multiple regions versus what you might just find in your local store. So, kind of the standard, Enfamil versus Similac, very comparable in price. But again, just general standard term formula, very costly if you look at, intake on a higher volume over a month period of time. The price is going to go up slightly with the Gentle Ease, and then, the Similac Elementum, of course, once you're getting into the Hydrolyzed, then down to the Elementals. I did put a metabolic on there, although usually, I know at least in Massachusetts, the metabolics are required to be covered by law, but it's something to still think about. And then cost of formula alone, another reason to really advocate, more use of breastfeeding, with your patients if possible, if you really kind of explain to families sometimes what the cost might end up being for them. The other thing on the bottom part of this slide is the Enfagrow toddler versus whole milk. So traditionally at a year, we're going to see our patients transition off of breast milk or infant formula, to whole milk, and a lot of patients are continuing on the formula using the Enfagrow toddler, but at the same time it's at a very large cost, and you have to really consider, if they're otherwise starting to include, a variety of foods and eating a balanced diet, then whole milk really is sufficient. If there's growth concerns, you probably still don't really even want to consider the Enfagrow toddler because it's only about, 20 calories per ounce, so it's the same calorie concentration virtually as the whole milk, so you're not really getting more calories, you are getting broader nutritional coverage, but might want to have to think about if growth failure, a higher calorie product like a Pediatric or a Boost Kid Essentials. So I think, obviously if you're looking at whole milk versus the Enfagrow and the cost for the family versus what the benefit or need might be, you have to, consider that as well. Preparation of infant formulas, this is something that I still see really on a day-to-day or sometimes even weekly basis where parents are mixing formulas incorrectly. They can mix formulas even just following the can instructions incorrectly, and then there's a whole different level of potential mixing incorrectly when you're using, higher calorie off-label recipes. And I think this is a real critical piece where, your community dietitian or hospital-based dietitian that specializes in pediatrics really can be an asset to you. So, you have to remember that not all infant formulas have the same mixing instructions. They all range in terms of their calories per gram of powder. Generally, it's that 2-to-1 ratio that we're going to see. But that's not the case for all of them. The other thing that can happen is scoops are not equivalent, so you really shouldn't use the scoop if you used Enfamil and you bought Enfamil this week and then you bought Similac the next week because it was on sale and you said, oh, I still have this scoop from the Enfamil laying around, I'm going to use it to make the Similac, it's not going to, equate as the same size scoop. Displacement is also a big issue, specifically when you're doing the higher calorie formulas. And, if they're not allowing for displacement, you can really lead to dilution of the product or overconcentration. And you have to remember that the recipes are not interchangeable. For example, I have there, if the parents had been on Enfamil, concentrated up to 26 calorie per ounce, and all of a sudden you needed to adjust them to, a hydrolyzed product like Elementum, you can't just say, oh, we'll make it the same way you were making the high calorie, Enfamil. There's going to be some changes in that recipe. And it's a lot to keep up with and to try and provide these accurate recipes for the families. And so it's a really good time when you should, look at how you can use your dietitians for this. So here's a sample formula preparations instructions as you would see on the can. So again, if you just look at the, calories per gram of powder here, it's pretty varied, although seems relatively close. And then, measured water per scoop. Again, usually you're seeing this 2-to-1 ratio. But again, the Neocate is actually a little bit different in that it's a 1-to-1 ratio. So, you have a failure to thrive infant. They're not meeting their weight gain goals. You really need to increase their breast milk or their formula fortification up to 24 calories from the 20 calories. Where and how do you provide that recipe for them? So, the questions I have is an RD helping to ensure preparation and accurate mixing instructions. Are you giving recipes in scoops or household measurements? Traditionally, what we do at our institution is actually do household measurements when we're going off-label to make high-calorie recipes. Scoops are certainly more convenient and easier to use, but what happens is sometimes you end up with odd measurements, like a third of a scoop, which I find for families is really hard to say, one caregiver to the next is going to, eyeball a third of a scoop very differently. We've also found with some of our non-English speaking families that using measuring spoons that are colored, and we tell them, how many numbers of colored spoons to use can lead to more accuracy. The other thing that we have at our institution that's really helped, I think, in some of the community pediatricians within, our practice is that we actually worked together. We, as dietitians, made recipes for 22, 24, 26 calorie per ounce, for various formula products. And actually, we have those online on a website that all the MDs have access to. And, they're able to give, their patients a safe recipe without always having to, consult one-to-one with a dietitian, for standard recipes. So that's been really helpful and something that I think, people should consider if something that you're needing to do frequently in your practice. So preterm formulas for term. So the preterm transitional feeds that we usually see are NeoSure, Emphacare, and actually Gerber has a Nourish, which is newer to the market. And basically, they're not indicated for term babies. I think the biggest thing that everyone looks at and sees is that they're 22 calorie per ounce, so they're higher calorie. And I've seen this happen multiple times where I have patients coming in where their community pediatrician actually placed a failure to thrive term child on the transitional preterm feeds because it was giving more calories and it didn't require them to give a specialized recipe. So, the things that really come with these transitional feeds is not only higher calories, you get higher protein, which, in most cases is okay, but you really get higher amounts of phosphorus and calcium. And I have seen serum levels of calcium and phosphorus slightly elevated with term babies that are using transitional products. So, again, a reason to just be more aware about, what really is in all these products. And, it's hard to keep track of and remember and know. So that's a great time to, again, kind of look at your dietitian to say, well, is this appropriate for this patient? Tell me more about this preterm product and, who should I be using it for? Vitamin D in term infants, so, we all know the recommendation is for 400 international units of vitamin D from birth. And, really to reach that goal, you should be giving all your breastfed patients a full 400 IU starting within days of birth. And the formula-fed infants actually should also be getting a supplement of 400 IU of D per day. And I'm really still seeing, surprising that these recommendations have been out so long, that this isn't really happening. I'm seeing, babies that are, 2 months old coming into the hospital, and I ask, well, have you been giving vitamin D? Have you talked about it with your pediatrician? And, the answer is usually no. Sometimes it's happening and sometimes not. More so, I think, with the breastfed infants because that's been the more long-standing recommendation. But I think sometimes it's kind of, misleading about the formula because, yes, we know it has supplemental D in it, but still until they're taking very large volumes, they're not going to reach that full 400 international units. So down here on the bottom of this slide, I actually highlighted Enfamil Newborn, which, is relatively newer to the market, targeted for the first 3 months of life. It contains slightly higher vitamin D at 75 international units per 100 calories. But only 16 ounces at the standard concentration is going to provide you 240, so it's about half of the goal. And I really don't see a child 0 to 3 months taking, drastically larger than, 24 ounces really maybe at the most. So they're definitely going to need some supplementation to meet their recommendation. Feeding the term infant, this is a question I actually get a lot, and it's about rice cereal being the first solid food. And I think more recently people have been moving away from this as a recommendation and not necessarily saying that it should be, and kind of offering other suggestions for a variety of foods to be introduced early on. Most of the time we're looking for it to be something that has good calcium, B6, the phosphorus, most specifically iron if it's usually a breastfed infant, and zinc, because that's where usually you're not going to have, most of those nutrients, where at 6 months you start to think about supplementation if there's not a good variety. So, something to consider too is, pureed meats or beans or legumes as some of the first foods that you could be introducing. And I think this is kind of way out of the box for a lot of people and a lot of parents that still are used to that traditional approach of, offering the cereal first or maybe some fruits and vegetables. And there is research to support that, giving the cereal before bed does not lead to sleeping through the night. And that's a common practice that I think a lot of parents are still, passing on to their children that have new kids, about, trying to, put the cereal in the bottle or giving cereal right before bed to help them, sleep a little bit more. So, key, and I think part of the reason why I tried to put all these slides in about remembering the term infant and feeding is that I'm finding sometimes the patients aren't getting a lot of counseling, and parents are coming in with sometimes what I consider to be pretty routine questions about when and how to start and offer foods, and they're very hesitant and reluctant to start to offer things. And then I can see that practice kind of snowball, for example, into, some more behavioral eating problems as time goes on, because starting with these, behaviors early and offering different variety of foods, really sets the stage for their future. So, some of the guidelines are, trying to have the infant really experience it. And, usually we're going to avoid mixing things together when they're first offered so that they can really kind of enjoy each different piece of what they're eating. And that there is research to show that infants do display some taste preferences. And again, remember, those are preferences and they're not setting the stage forever. So, if your infant is refusing green beans or carrots, at this infant stage, it's not to say that you need to check those off the list and say they'll never eat them again. Introducing, again, a variety of foods by the first year to facilitate the development of healthful food habits. So, again, I talked about this a little bit earlier in the slide, where it's just really setting the stage, and it's important. I think this number right here, 10 to 20 exposures before a food is accepted, is a number, that I'm surprised parents are kind of unfamiliar with hearing and, shocked every time that I tell them, oh, well, how many times have you offered it or tried it, and which different ways have you offered this certain food? And, I say, oh, it's, we have to think about, 10 to 20, sometimes even more exposures over time before they might be accepting of this food. And sometimes I get a big blank stare back at me, saying, well, whoa, I had no idea, I really needed to try that hard. And, there's this sentence down here, really that, again, setting the stage where you're, more exposed to a variety of foods, it's just only going to benefit them in the later years, which is where you're usually going to have most of the problems with picky eating and limited diets. So, this question, I feel like I keep saying this question keeps coming up, but, again, like I said, I really tried to pull these slides based on, what I'm seeing in practice, on the inpatient side and what's happening. And, everybody's obviously concerned about obesity in our pediatric patients, and, do we really still need to be offering the whole milk, right when we're transitioning, or, should we be looking at skim milk, or, the latest thing that I think is a little bit part cultural crazes, the almond milk, you know, and people think, well, that's so much more nutritious. But, you know, again, with that, you know, first, you know, 2 years of life, it's still the most rapid period of growth, and you really don't want to have, you know, blatant fat restrictions. So it's really difficult to kind of have these infants, these really toddlers, you know, meet their nutritional goals when their fat is restricted, and still a large portion of their intake usually can come from their milk source. So you also think about the fat-soluble vitamins if they are restricted, leading to potential, you know, visual or cognitive, you know, delay, and, you know, potentially decrease their peak intelligence. So the next slide that I have actually has the nutritional content of milk and some of the milk replacements, which, you know, comes up frequently, you know, specifically with, you know, our high population of allergy patients now needing to avoid cow's milk protein. So, you know, kind of looking at, well, what's the alternative? So, you know, I think this is still, you know, whole milk versus skim milk, I think, is still a little bit of a teaching point that needs to happen with a lot of families where they don't really understand, you know, the differences in that, you know, they think they get more of everything in whole milk sometimes as they get older, when in fact you're still getting the same amount of protein, you're just not getting the fat, which at, you know, after 2 years you really should, you know, at least work down to 1%, ideally skim. Then, you know, the next kind of product that usually people will default to would be soy milk if you can't have the regular cow's milk in place. But, you know, you can see you definitely lose protein, and you lose some of the fat too, as well as then that leads to reduced calories. Rice milk, very low in fat, but sometimes can have a lot more calories to it, so you have to kind of weigh, you know, the pros and cons there. The almond milk is the one I really like to highlight because a lot of people are using it, and it's very low in calories, very low in protein, you know, and also low in fat. And so it's really not providing a lot of, you know, nutrient value to patients if they really need, you know, some better balanced nutrition and more adequate calories. And hemp milk is on there too as an alternative, which actually has a little bit more protein than the rice and the almond milk, but sometimes may be harder to get. Organic foods. So are organic foods easier to digest and absorb, contain higher quality nutrients than non-organic? The studies are really conflicting, but there's still risk that actually your organic foods could still be contaminated with pesticides. You know, there's an increased risk for foodborne illness. They are going to spoil quicker. They have more cost. And, you know, really there's no said health advantage to the organic, and I think it's, you know, a constant struggle for our pediatric patients to actually consume and eat fruits and vegetables, you know, let alone trying to push and make them exclusive to all organic foods. And I've had conversations with plenty of parents, you know, many of them very well educated, thinking that there's actually, you know, a real strong specific nutrient and digestive advantage to organic food. And when I tell them that that's just really not shown up yet, you know, they're really surprised because that's what they're feeling like they're hearing, you know, out there in the regular world. So, you know, what do you say to the parent that insists, you know, I have to be exclusive all organic? You know, you have to step back and just remind them of the importance to, you know, have variety of foods to reach nutritional adequacy, that, you know, you just want to limit exposure to a single contaminant. So, you know, trying to buy your produce in season when possible, always using safe food handling practices, you know, washing your hands before you're preparing things, using appropriate cutting boards for certain foods, and washing and rinsing your vegetables and fruits well before you're using them. And that, you know, sometimes the prepared products that are highlighted, you know, as organic also sometimes can be very high in fat and added sugars. And, you know, it's another thing to just step away and remember that the label organic does not necessarily equate to healthy or better nutrients. Vegetarian and vegan patients, definitely, you know, more so. I think a lot of times I'm seeing, you know, some patients come in, you know, based on maybe the beliefs that their parents have, or, you know, the parents are trying, you know, to have a diet based more on, a celebrity lifestyle effect or things like that, and you're, kind of getting a lot of these restrictions. At the same time, you see the vegetarian and vegan patients, and they have a strong rationale for, why they want to follow the diet, but you have to remember that, it needs to be done safely and consciously so that they're getting adequate nutrition. And there's indication that sometimes the vegan children specifically, actually have higher protein requirements than that of a non-vegan child because of the differences in the amino acid composition and the digestibility of the plant proteins that they're eating. And actually, there's the percentages there on the slide with, maybe even up to 35% more protein required, for 1 to 2 years versus, a non-vegan patient. So, the difficulty comes down to, are they vegetarian, are they vegan? But if you're looking at, some good examples of protein sources, obviously the legumes would be big on the list. The soy-based products, nuts and the nut butters, seeds and seed butters, which I find can still be a really difficult challenge because of a lot of the nut-free daycares, schools that are out there with the increased allergies. So you kind of have to look at the seed alternatives as a good source, and those are also usually still containing some good fats. Grain and grain products that are enriched, dairy products, cooked eggs, again, more of a challenge with the dairy and the eggs if you're dealing with a vegan patient. Omega-3 fatty acids, usually not a huge issue, but again, if you're excluding fish from the diet, then you might want to recommend a DHA and EPA supplement that's coming from the algae specific, which I find you can usually get in, most of the health food stores now, as well as a lot of the chain pharmacies. Iron, so iron bioavailability, we know is lower in vegetarian children, so you're really looking for those iron-fortified grains to be consumed in cereals, and then looking for your iron sources of vegetables and legumes. Zinc, again, because they're reduced by the phytate, then, where you're kind of already increasing that, you might need to have a little bit more zinc. So again, looking at maybe nuts and tofu, some of the fortified products that are out there with extra zinc in them. Calcium, we know there's lower calcium intakes in the vegan children. Calcium fortified non-dairy drinks or foods, which I think, somewhat can be a little bit difficult to find. It's interesting because I was recently, again, I've seen this new product kind of being advertised on the market. Ella's Organics makes a lot of, the pouch-based variety of foods, and they have a new, they tout it as a nutritional drink with, coconut milk and added nutrients. And I was interested, so I looked closer at the nutrient content in it. It has no added calcium. It has no protein. It's 20 calories for half a cup serving, so about 5 calories per ounce. And it also had no added fat to it. So I was really wondering what the benefit was that made it very nutritional. But these are the type of products that are easily, marketed. It's beautiful colored package and says nutritional drink right on it, and can be very deceptive to parents that have no understanding about the nutrients that they should be looking for to be present in these products. Then again, B12, I think that's the most common one that you think about with your vegetarian or vegan patients, and that they might really need to look to have supplementation, usually in the form of a B complex or a general multivitamin. Picky eater, so, really the initial slides that we're, really looking at the infant and setting the stage early, carries on to this. And this is, always and will be, I think, a constant struggle for, everyone involved, for a dietitian counseling families, for the pediatrician, for the parent, because it really just takes a lot of, hard work and persistence and encouragement. Setting the tone early in infancy is really the best thing to do. So, we need to maybe look and focus more counseling to that, first year of life with introduction and recommendations around solids and strategies and what to expect and what you might actually get from their first eating experience. Staying determined, not giving in. Several attempts, again, thinking of that 10 to 20 rule that might be out there, and maybe even, setting the stage early and letting them know that number early on so that when they're at their 5th attempt of, a food thrown at them or thrown on the floor or spit out, that they're not saying, okay, well, that's the last time I'm, going to offer that food. He clearly doesn't like it. Having it be fun, have them help set the table, menu plan, go food shopping, crack the eggs, participate. A great time to set the stage for a lot of overall good positive behaviors and helping around the kitchen and being engaged in what is going on there. And not force feeding. Really, some of the most severe, older age failure to thrive cases that I've worked with usually involve a caregiver ultimately chasing their child around with a spoon, trying to get food into them while they're running and playing and being distracted. And it just really results in not good nutrition and, setting the stage for positive eating. So trying not to trick, bribe, or force them into any new food, but, having them be part of the conscious decision to, eat what's on their plate. And really routines are key. That grazing can really cause, some poor intake and growth patterns because, they'll, maybe be offered a meal and, just kind of let to be played around. And then, the next thing you know, they didn't really eat much. And so then, they're asking for a snack or even more often juice, in between. And then that's filling them up. And then they're not really ready for their next meal and, kind of leaning towards, not as nutritious foods when they're on that grazing pattern. Always encouraging all of our patients to sit at a table to try and limit distractions, using a high chair early on, even for snacks so that they understand that the focus of the time right there is really for eating and enjoying and learning about food and not for other things. And most of all, I think the biggest thing to remind all of our parents is that we need to be a good example. And this can be hard. I am myself a mom of 2 and full-time, working mom, and it's hard to, always have a good, healthy dinner and other meals planned. And, it's about balance, but, we try and, do our best to have good manners and, learn about foods and eating the right foods and, trying to be the best role model we can about, not, for example, having a vegetable on our plate and saying, ooh, yuck, oh, ew, I would never eat that, as a grown adult. Or, even I've had stories of parents that say, oh, I didn't like that and I spit it out. And, the kids really absorb that. So, it's important to set the stage yourself with being a good role model. And it's hard when we're busy and on the go and, you're just saying, oh, well, we'll just grab this. But, it's to try and be a focus as much as possible for all of us. And how much should our kids eat? I think this is still, and even myself as a dietitian, you sometimes forget, well, wait, what are the real portion sizes? How much should this age child be eating? So the next couple slides have a few examples of, appropriate serving sizes. So this one really would be towards meats, which would include like beef, pork, or poultry, or fish. So your toddler age, really only 1 to 3 tablespoons. So you think about 2 tablespoons, usually the size of like a ping pong ball, for example. It's not really a lot, but it's adequate for them as a serving size. School age, 1 ounce. Adolescent, usually 3 ounces. So 3 ounces we think of often as, the size of the palm of our hand, a deck of cards. So, only 1 ounce would be, really a third of that deck of cards that you'd be looking for. Sample serving size of grains, so, like a bagel or a bread or a bun type of thing, or the rice and pasta. So a toddler, 1/4 cup to 1/2 of a cup, and then you can just see clearly, school age, they're still only really recommended to have about 1/2 as a serving size, and adolescent, then you'd expect maybe a full cup of rice or pasta, or a whole bagel or a bun. And I think oftentimes we're seeing toddlers in school age consuming 1, even, up to 2 cups, might be offered as a meal, versus just having smaller portions and a variety of foods. Vegetables, so this is for cooked. So again, your smaller portions for your toddler, 1/4 to 1/3 cup, really up to 3/4 of a cup for the adolescent. So it's still, smaller quantities than you probably, generally think. And here's a good visual guide to portions. So again, when we talked about, the tablespoons, ping pong ball size, the deck of cards for the meat guides or cheese guidance for ounces. The size of an egg, usually you think of as a quarter cup, half cup, usually a standard computer mouse. Tennis ball is a little bit smaller than the baseball, so there's kind of your difference if you're thinking about 3/4 of a cup versus 1 cup, because, it's not expected that everybody just sits around measuring cups and tries to portion out, their kids' foods. It's kind of just getting an understanding of what portions mean, and definitely, I think this is a hard thing to have parents even grasp, let alone be able to, teach and pass on to some of the adolescent kids. So, really where can RDs come into play? We can provide accurate recipes and educate the caregivers on really how to safely prepare high-calorie infant formulas. We can work with them on portion sizes, and we have lots of resources and access to create, age-appropriate sample menus for patients. Working on, doing more thorough counseling on the positive mealtime routines and behaviors, and maybe it's a time where, we step back and look at the benefit, of a nutrition-based, feeding therapy where you have a dietitian, you have usually occupational therapist, feeding specialists sometimes, as well as speech-language pathologist, and really have regular visits to improve therapy and, trying to get patients in and engaged in those experiences early. If you see really, high-risk behaviors around meals, might be a good idea. And to really just support and offer guidance to the parents that are struggling with picky eaters, because I think, at least I personally feel a lot of the parents, they feel like they're failing, that this is, one of their roles is to, adequately nourish their kids. And when they're not able to do that, they feel, very much, challenged. So it's, good to offer support. And the thing that I try and do most is really just look at growth and step back and, look at the growth and, how at risk is the individual patient.